Thank you all for coming to hopefully find out something about proton therapy. So I have thought long and hard about these slides, about what people would want to know about, and certainly I've been in the game for quite a few years and seen various issues come and go in terms of the way the press has reported it and the way the health service is implementing proton therapy for patients. So hopefully you'll find what I've got to say interesting. And I also want to say happy birthday to the NHS, 70 years this year. Right. So what is proton beam therapy? Well, proton therapy is another type of radiation therapy. What we use in proton therapy are protons, and essentially they're hydrogen ions. So it's the proton from the nucleus of a hydrogen ion with the electrons stripped off, rather than the standard photon or X-ray-based treatment, sometimes shortened to XRT. Other ionizing radiations are available, but essentially I'm going to focus on protons, but I'm going to start talking a little bit about photons. I know this slide gets rolled out quite often, but as a clinical oncologist I love it because it tells me that I'm relevant and the treatments that I deliver help patients and cure patients. So radiation therapy is responsible for cure or significantly contributes to it in 40% of long-term survivors. So down to the issue, toxicity. It is a great treatment for cancer, but toxicity is a concern. Not just the acute toxicity of treatment whilst patients are having it, but also the long-term toxicity, which can happen 5, 10, 15, 20, maybe even 35 or 40 years out from treatment. It's also a highly emotive issue. You may have noticed in the press there have been stories linked with radiation therapy and also proton therapy in particular in the press over the last few years. So it's been an environment, of course, I'm aware of as clinical director of the service that's about to open in Manchester, and clearly public perception is important, and stories like this do occur with some regularity. As clinical oncologists, we're aware that radiation therapy causes toxicity, specifically late effects. What you must understand about radiation therapy is that there are factors which you can control. And actually over the last few decades, there have been great strides and advances in the way radiotherapy is delivered. Either more conformal treatments, that's giving dose as much as you can to the tumour and giving lower doses elsewhere, or image guidance, improving the accuracy of treatment and the way we deliver treatment. But the three aspects that you can control or at least consider to some extent are these. The effects of radiation therapy are spatially defined. I've never seen a radiation toxicity in an organ that hasn't been irradiated. And that stands to reason. So you've got an example there, late skin toxicity. So this lady has had irradiation to the left side of the neck. Here, irradiation to the lung causing fibrosis, and here, radiation to the leg, which has caused a bone fracture some years down the line. Toxicity, or the extent of toxicity or degree of toxicity, is age dependent. We know this. Young patients, pediatric patients, before they've attained their final height, if you irradiate the spine or you irradiate the brain, which produces the hormones that stimulate growth, can cause problems with bone growth and final height attainment. This young man here has had a tumour treated in the left-hand side of his face, and this has caused problems as his face has grown over time. And we know when we irradiate the brain, the younger a child is, the more impact it has on IQ. It's also dose dependent, and this probably goes back to the first point there. the higher the dose to an organ, the more toxicity you can expect. In my daily practice, I use this concept of threshold doses. I don't want to give a dose above a certain level to a particular organ. Those are threshold doses, but I work in pediatrics. I'm acutely aware of all of this, so I try to keep those doses as low as reasonably achievable. As I've said, X-ray-based therapies have advanced considerably. Apologies. There are 3 buttons on this, and the laser one isn't in the obvious place. There we go. So, in the early days of radiation therapy, actually predating this, they would have used radium or some other radioactive material to produce the X-rays. And then low energy X-rays, and then we sort of arrive in the megavoltage era over the last few decades. So we've got a standard linear accelerator there, a tomotherapy machine there, which essentially is a rotational device for delivering radiation treatment, and then stereotactic surgery. And as I said before, it's not just the mode of delivery and the software which has played an important part in how we deliver treatment, but also the image guidance capabilities of these technologies. So, what I'm showing here, this is a tumour in the abdomen of a young child, and the standard approach historically would have been a parallel pair. So essentially you're irradiating a tract of tissue which, yes, contains the tumour, which is here, but is also irradiating much more than that. With advances in technology, intensity modulated radiotherapy and volumetric arc radiotherapy, for example, we're able to conform the dose much closer around the tumour, but that has generally led to this low dose wash in the rest of the body. So that's where we are with X-rays. Say hello to the Proton. So I'm an adopted Mancunian, so very proud that it was discovered in Manchester about 100 years ago by Sir Ernest Rutherford, and that was at the Victoria University in Manchester, which is now the University of Manchester, and his laboratory still exists. So what's special about them? Right, I know this looks complicated, but I will walk you through it hopefully. This essentially shows you dose delivered depending upon the depth of tissue in the body. So if you can imagine a beam coming in from the left-hand side of the graph, and where naught is there, that's the skin. This shows the dose fall off from the radiation therapy. This black line is X-rays, or photons, confusingly called. And what you tend to see is you get a spike of dose deposition and then it falls off. Protons are different. That's the dark blue line here. And it has this property called the Bragg peak. So yes, there is some dose delivered as the beam enters the body, but at a particular point it deposits the great majority of its dose at a particular point, and you get absolutely no exit dose. Now there's a tumour there represented in brown. Clearly this Bragg peak is too narrow on its own to do that. So what you tend to do is you tend to spread out the Bragg peak, and that's in the mid blue here. And that's done by altering the energy of the proton beam. The higher the energy, the more it penetrates, and the greater the distance that the dose is deposited in the body. So by gradually reducing the energy of the beam, you can actually cover the extent of that tumour. And on this very, very simplistic representation, I've got to admit, the dose that you spare is essentially this area here and this area here. So less dose to normal tissues. So what are the clinical benefits of this? Well, I think the main principle that I always rely on when I'm speaking to patients is no exit dose past the target volume being treated, i.e. the tumour. keeping dose to the normal tissues as low as possible, and do not irradiate what you don't have to. This reduces damage to the normal tissues, which is a major motivation in most of the pediatric and young oncology patients that I see. But also for some tumours which are next to critical structures, for example next to the brainstem, you can actually give higher doses of radiation that you could normally do with X-ray-based therapies, because you're not depositing the dose in the brainstem, so you can actually give more to the tumour whilst still giving what you would have done with a standard dose treatment with X-rays. So you remember this. This was where we're up to with photons, X-rays, and you get this low dose wash. I tried to find a similar patient, not exactly the same patient, but a similar patient to plan with protons, and this was as near as I can get it. And actually, this is a larger area that needs treated. But as you'll see, there's no exit dose there. So you can get quite a substantial sparing of the normal tissues. Now, many would argue, and I completely agree with them, much of this is of a very, very low dose and probably inconsequential to the patient. Though there is a second malignancy risk associated with low dose radiation. And so that's a particular concern in young people, whether they be children or whether they be teenagers, because they have a long time to live and a long time for cancers, second cancers to develop. And actually, when this technology was being introduced, I was a little bit reticent about its sort of introduction, certainly for my younger patients. But quite often, it is the best way to get that high dose around the tumour. Here's another example. This is a tumour of the spine, liver, heart, lungs represented. And this is with protons. So this is sparing those normal tissues. Now, one of the myths. Protons have no toxicity. And that's the way it's often sold, and it is completely false, because you're still having to irradiate a volume, and you're still actually getting quite a bit of entrance dose. And very, very rarely would you ever treat a tumour with just one beam. You'd use 2, 3 perhaps. So you're getting more entrance dose in doing that. So there is toxicity, and I'm just going to use this slide to illustrate it. I'm using this for 2 reasons. This is a craniospinal treatment for a condition called medulloblastoma. And on the right, we've got the standard X-ray-based approach, using very, very advanced technologies, intensity modulated radiotherapy. And on the left, we've got protons. Now this is actually an older patient, and that's why they've been able to stop halfway through the vertebral bodies. I wouldn't have done that in a child, otherwise the growth of the spine would have been abnormal. You are still irradiating the brain and the spinal cord, and there is toxicity associated with that, whether that's an impact on IQ, whether it's an impact on hormone production in the body, growth hormone, etc., etc. You are still going to get that toxicity. What you spare, of course, is the heart, the lungs, the thyroid, and perhaps the ovaries. And I also like this slide because it shows you that the protons do indeed stop, because half the marrow has turned white as an effect of the radiation therapy, and the marrow is maintained at the front of the vertebral bodies. So what's the technology we use to deliver this? Well, essentially protons are produced either in a cyclotron or a synchrotron or a cyclosynchrotron. I'm going to focus on the cyclotron because that's what we've got. And this is a cyclotron here. This technology is rather large. Even the more compact solutions of this technology do take up quite a bit of space. So you've got a cyclotron, it produces protons, goes down the beamline and treats the patient. And I show this slide really to show the scale of the patient with the scale of the gantry. This gantry goes over 3 floors. So let's delve a little bit deeper. So this is a cyclotron, and essentially what a cyclotron does is it makes a plasma out of hydrogen, strips the electrons off and produces protons. And within the cyclotron, once the protons are produced, you've got these alternating fields on what are called D plates. And what that does is it simultaneously attracts and repels the protons. They start spinning round very, very, very fast, hence cyclotron. It's a bit like a washing machine. When they get to the edge, they're so fast, they come out of the cyclotron and down the beamline. And that's where they will travel to the patient. So on the right here, you've got a gantry. The patient doesn't see that 3 floors of technology behind, but the gantry is rotating around the patient on the couch there, getting into position. And this is going to show the treatment of a pelvic tumour. This is a scanning beam, and there are very strong electromagnets directing where this beam goes. How deep the beam goes is dependent upon the energy of the beam, and you select that in the beam line. And essentially what it does is it paints the dose from furthest away from the machine head and then brings it towards the machine head. And this actually happens very, very, very quickly. Another myth I want to dispel is that the NHS service is not new. I know I put it in the title, probably my fault. So apologies if I confused you there, but there has been an NHS Proton service for some time. The first one was actually a bit of a game changer, and that was the Clatterbridge service, which is near Liverpool. And they treat eyes, predominantly melanomas at the back of the eyes. And it was the first hospital-based proton therapy centre in the world. So that's a huge, huge achievement for the NHS at the time, and it's still going, and it is a fantastic facility. It is a low-energy facility, and that's why it treats eyes. What I'm focusing mainly on in my talk is high-energy proton therapies. And there's been a service there too. Patients have gone abroad for high-energy proton therapy since 2008. As you can see, the numbers have gone up and up and up over the years, and the current providers for that are Jacksonville in the United States, Essen in Germany, and the Paul Scherrer Institute in Switzerland. And the NHS funds treatment, associated medical costs, travel and accommodation. And it is a very successful service. The Christie is going to hopefully strengthen the service that the NHS provides later on in the year, and we will join an ever-increasing number of particle therapy centres worldwide. And we're just part of an evolving NHS provision for proton therapy. So we've got the current pathways, and then later on in the year, the Christie will start taking patients. We won't start at full capacity. We will need to what we call ramp up, and I'll come on to that in a little moment. And then UCLH, who is building another facility, and you could probably pass it when you leave here, a massive construction project with their proton centre underground, and they're due to open in 2020. So what's the NHS England approach been? Well, significant investment in the overseas programme since 2008, as I've mentioned. Significant capital funding for 2 centres in England, Manchester and London, as I've already mentioned. And the primary motivation for this has been mainly around children, young people and rare tumours, but obviously the desire to increase capacity, to do research and other studies to look at how proton therapy could benefit other patients. Everybody gets very excited about the technology because it looks great, and the hairs in the back of my neck still stand up, when I go and see the cyclotron or look down the beam line or whatever. But it's the service wraparound that's so important for a service like this. And patient support, specific to the types of patients you are treating, is absolutely crucial. So from a technology standpoint. The NHS was very keen for multiple rooms with fully rotating gantries, advanced imaging capabilities to match what we can do in photons, X-rays, and intensity modulated proton therapy using that scanning technology I showed you. From a clinical service and patient support perspective, specialist experience, absolutely key. Many of the cancers we will be treating will be rare, and many of the cancers that are being treated overbroad currently will be rare. A hospital-based service which is fully integrated, so we've got pediatric, teenage, young adults, radiology, you name it. As a large cancer centre, we have the capacity and the services on site, most of the services on site to cater to our patients. Patients do not receive proton therapy in isolation from everything else. Children often receive multimodality treatment with combinations of chemotherapy, radiotherapy, surgery. And having all those services co-located is fundamentally important. And let's not forget emergency and critical care. Also having a trial infrastructure so that you make the best of the gift you've been given in terms of the technology. And also providing comprehensive patient information and support. And an advantage for us at the Christie, because we will be one of two centres, we feel our expertise is great in many of these areas, but it can only strengthen when the Proton service opens. One last thing, one service, two sites. We have not worked independently for the last X number of years. I still have weekly conversations with my counterpart down there, and we've aligned as much as we can clinical protocols, tolerance doses, and other aspects of planning. And in fact, we have the same technology. So we truly are sister centres in that respect. So what about the Christie Proton Centre? This is an unusually clear sky in Manchester. Just need a few ducks flying over. This is the Proton Centre here. This is an artistic representation, by the way. I don't want you to be disappointed when I show you the current shot. But this is, which is still lovely, don't get me wrong. But this is the Proton Centre, and this is our Oak Road reception, which has recently been developed. We've got our Oak Road Treatment Centre here, which does chemotherapy, largest phase 1, phase 2 trials unit in Europe, and we've got our investigational procedures unit just there. The Proton Centre is multi-level. Obviously the gantries go over 3 levels, so it just made sense to put our services on a number of levels also. And this is the configuration of the Proton Centre. Our cyclotron is called Emmeline. Can any of you guess why we've called our cyclotron Emmeline? Any famous Mancunians you might know? Emmeline Pankhurst, absolutely. So our cyclotron is named after Emmeline Pankhurst. We've got 3 clinical gantries, and we've got 1 research room, which is occupied by the PRECISE group, which is a collaboration between the Christie and the University of Manchester, and much of our preclinical research will go on there. If the time comes where we need to increase capacity, 10, 15, whatever years down the line, then we have the space to do that. And we will treat somewhere between 650 and 750 patients per annum. It's been an absolute joy watching this thing grow out of the ground and watching it being constructed. And this is a lovely shot. Again, actually relatively clear skies. I wonder why. This is the side of the building where the gantries are, and actually this hole here is where we drop, well, not literally drop the gantries in. That's where they were lowered, you know, ever so gracefully. So our gantries went in there, and then we put essentially concrete planks on the top, crisscrossing over each other. And this is the clinical side of the building. The finish is coming along nicely. This is the reception area. This is a one-man desk. I couldn't understand why you could fit at least 4 people behind that. Apparently there is a reason. But it's looking very nice. This area here, interestingly, is where our social workers are going to be. And there's also going to be a school there for our younger patients. So we have got funding to provide schooling for these patients. Radiation protocols generally last over a number of weeks, generally daily treatments, Monday to Friday, 4 to 6 weeks, something of that ilk, and it's no different for protons. The headline dose and the headline fractionation will stay the same. So we've got a school planned for there. This is the pediatric waiting area. I know it looks very neat. Clearly you can tell no children have been in it. And it also needs pictures. But those are coming. So that's our pediatric space. We also need space for anaesthesia, and we've got a rather large anaesthesia service to accommodate, because many young children just cannot lie still for their treatment. Proton technology has come on leaps and bounds, and actually treatment times are quite good, about 30 minutes or thereabouts, which is in line actually with our standard X-ray treatments. But we still need an anaesthesia service, and because patients will travel far and wide to us, we may not have the time, all of the time, to do the intense sort of play specialist work that might be required just to calm their nerves. So we've got in total 3 induction rooms, 2 that service the gantry corridor and 1 for the MR scanner, and we've got a first phase recovery for the child to wake up in, and then next door there is essentially a day case unit or second phase recovery. This is an internal courtyard for the children to play. I hadn't realised there is still a brush there and what looks like the cover to a Stanley knife, so I do apologise. Obviously that will be all cleared up, but this internal courtyard is very safe and the patients can be out of the rain in the waiting room, and their children can play. So hopefully I haven't disappointed you too much with the externals. I think it's quite a handsome building, and it is very large, and interestingly it actually occupies the site of our old young oncology unit, so I think it's very fitting that it sits there. We do still have a young oncology unit. It was moved to a new residence on the other side of the hospital. Our cyclotron, Emmeline, this is her in situ. And this is her opened up because I mentioned D plates before and where the protons spin around, and this just lets you look inside her. The gantries are also taking shape. So you know, this is 3 floors. We're having to put a floor in, and the couch there for the patient to lie on. And again, that's really come on greatly, and we're now just putting the finishing touches to those rooms. So what about the clinical service at the Christie? So what cancers will we initially treat? Well, as I said before, patients are already going abroad for proton therapy, and essentially what our function will be when we open is to repatriate many of those patients that would have gone abroad. Not only that, but allow patients to have proton therapy who couldn't previously go abroad, either because they were too unwell or their treatment pathways were so tight it was more important to treat with radiation rather than to wait for proton therapy. So it serves dual functions there. Many of these tumours are tumours of childhood, so rare, so you may recognise a couple of them, but there is a wide range there. Not just children, but teenagers and young adults as well, and also some adult patients. You remember I talked about dose escalation, giving more dose to a tumour that's close to a critical structure. So there are some examples there, chordoma, chondrosarcoma, which tend to be sort of base of skull tumours next to the brainstem and spinal cord. This is a representation of our ramp up. We're not going to open all guns blazing, all gantries, starting treatment at the same time. We'll open with 2 gantries. That affords us a little bit of flexibility. If we have an issue with one gantry, we can use the second one. But paediatrics and teenagers when we open. So it's not an easy case mix, and very few centres in the world have opened with that particular case mix. An exception is St Jude's, which is a paediatric hospital in the United States, Clearly, they opened up treating children, but many centres around the world have tended to use older patients with tumours in easier locations to treat. And we will ramp up over a period of about 18 months or so. So what about the patient pathway? So clearly there'll be patients from Greater Manchester, that's fine. We already have pathways in place there, but there'll be patients from around the country also. And the current mechanism for referring patients is through an email. That's going to change shortly. There's going to be something called the referral portal where all referrals are done electronically. Once that is in place, we will receive referrals through that. They will come to our hospital, those referrals, and on discussions with NHS England, because our capacity is limited at the start, which patients should we treat and which patients would be best going to an overseas provider either in Germany or the United States. So we will manage our capacity that way. When we do accept a patient, we will have a discussion in what's called a multidisciplinary team meeting. Multidisciplinary team meetings in oncology are prevalent. This is a slightly different flavour of team meeting. It isn't just staffed by clinicians, but there are also physicists and a range of key workers and pre-treatment planning, etc., who are all present. Because remember, we're discussing a patient in isolation. We've never seen the patient. We don't know what their circumstances are, for example. So we've got lots of things that we need to sort out and discuss before we actually see that patient in clinic. Our MDT room has the facility for colleagues to dial in from around the country, and that would be extremely useful to us. If we say yes, they would benefit from proton therapy and no other further surgery or chemotherapy, etc., is recommended, then the patient will be invited to come to, and their families, to a single stay assessment visit. So the patient will come to an assessment clinic and everything will have been pre-arranged. Essentially, it's a one-stop clinic, but it lasts over 3, 4, 5 days. For pediatric patients, that may involve going to the Children's Hospital to discuss chemotherapy, those sorts of issues. And any baseline investigations that we need to do, we can also organise for that time. The patient will then go away and we'll plan the treatment. And that process will take about 2 weeks. And we've been very careful to ensure that there is consistency across the service. We will have peer review meetings where we will peer review, i.e. colleagues will basically look at the plan I've done and tell me if I need to do changes. And I'll do the same. But we think that process is very important for these rare tumours and this new technology. And then that plan will be brought back to that meeting to actually see what the final plan looks like. Then the patient will arrive and they will receive their treatment, daily treatment. They will be accommodated in Manchester, and that is funded unless the patient is particularly local and prefers to travel. If you've got a family, it may be easier just to drive daily for treatment. When our service is increasing, its capacity, its activity is increasing, then we will go to extended treatment days and we will be operational early morning to late evening. So we'll probably schedule our last treatment just before 9 o'clock, actually. You can't treat round the clock. A, patients don't like it, and B, the engineers need to get in there. They have work to do. They have quality assurance to do. And also researchers need to get in there. You notice there is one cyclotron. Cyclotrons are very expensive. So that's why you've got one cyclotron servicing 4 rooms. And you actually have to wait for the beam in each room. Now actually, because the treatment times are so short, you can request the beam and you actually get that in a matter of minutes, mostly. But the researchers need to have continuous access to the beam, and they will tend to do that in the early hours of the morning and at the weekends. Occasionally, if we have issues with the service, we may treat at the weekends. Training has been a huge effort, not only for ourselves, and I know for UCLH also. And clearly we've recruited new staff, but there is a rather large core of personnel over the last 3 years have been trained, and that's been a combination of going to educational programs internationally, visiting other centres. This is Maryland, I was there for a week. This is Jacksonville in Florida, where our patients go. I've been a couple of times. We actually got some experts over from other centres to come and teach us, and that was a fantastic exercise. We showed our plans, they showed us theirs, and that was really, really useful. Paul Scherrer Institute in Switzerland, St Jude, as I've mentioned, and also UPenn. So, another thing that I've come to realise after a few years of proton therapy is proton therapy treatment planning is not like X-ray treatment planning. You cannot just transplant what you know about X-rays to protons. Protons can be funny, and I'll talk about where there's a bit of a diversion from how we would do X-ray-based planning and with respect to proton planning. So, there are some known uncertainties with protons. We know where they stop, and you actually saw an example of that with the irradiated spine and the changes in the bone marrow. We don't all the time know exactly where protons stop. Now, don't be too alarmed. That is a known uncertainty, and we can account for that. Protons are very, very sensitive to density of materials. They tend to deposit their energy, their dose, sooner if they go through bone compared to soft tissue. So actually very simple things like an organ moving in and out of the way, say the heart in the chest, for example, can actually disturb the dose distribution quite considerably. Or you may have a tumour that's shrinking and that's changing the whole density of that area, and so protons can become inaccurate over time. So imaging is absolutely crucial. Monitoring a patient's weight is absolutely crucial, because if they lose body fat, that actually reduces the distance between the skin and the tumour. And also biological effectiveness. We do know that certain parts of the beam are a little bit more biologically effective than other parts of the beam, and a lot of research has gone into that, and we are certainly going to do a lot of research into that. So I'm going to show you an example. This is courtesy of Dr. Julia Handley, who's a physicist at the Christie. It actually taught me a lot, her slides, so that's why I've used them. Imagine, this is a tumour here, this blue blob. This is bone. You very rarely find square bones, but you've got one here. And the beam is going to come in this way. So the beam is coming in, and you get this glow of dose around the tumour. What happens if the patient moves? Well, the middle of that beam is now going through high densities, so it's actually depositing its energy earlier. So there's two problems there. Firstly, you're not actually fully covering this tumour anymore. And secondly, you're actually giving dose to normal tissue that you hadn't perhaps anticipated. Equally, it could be the other way. The beam moves in the opposite direction with respect to the bone. So you've got those two problems, and it's especially a problem if you've got an organ sitting next, an organ that you're worried about sitting next to the treated volume. The second example I'm going to show you is weight loss. So this is the skin, and weight loss, the distance of the tumour relative to the skin gets smaller. And now, obviously, the gantry, the technology doesn't know when it's delivering this treatment that has happened. So it is delivering to the area that you planned and prescribed, but the tumour has now moved relative to that. So all these factors need to be accounted for during the planning and treatment process. So that's the technology, a little bit of physics and sort of practical issues that we're going to have to deal with. Pediatric patient support. I talked about that integrated service earlier, so important. This picture here by no means has everybody in the pediatric team on it. It was ones that could actually turn up on the day in the Christie garden, but we've got representation from most disciplines, nurse clinicians, nurses, anaesthetists, theatre practitioners, consultants, and key workers. The Christie has treated pediatric patients for many decades. This obviously is a substantial uplift for us when we start treating proton patients from around the country, and we've had to expand all of these disciplines. But we are getting a school, which is something that we never had before. And the relationship between ourselves and Royal Manchester Children's Hospital has grown from strength to strength. They're providing chemotherapy if it's required, if there's any surgery, urgent surgery required and the patient can't go back to their referring centre, providing us radiology support, especially expert radiology support in the MDT, shared care arrangements, outpatient and inpatient care also. This is a kitten scanner. So we've got an MR scanner and a CT scanner for radiotherapy planning or proton therapy planning. And this is basically just a baby MR scanner that you put a doll on and it scans it and the kid can see the pictures. It's great. And we're also building a mini gantry for children to play with before they actually go in the room. And this is our play specialist pen, and we're increasing that team in the anaesthetic team. And also an app where children can create avatars of themselves and virtually explore the Proton Centre. Teenagers, older teenagers and adults are not left out. There is a vast range of services available to them also, as you'd expect in a comprehensive cancer centre. We have a Maggie's. I know many cancer centres around the country have a Maggie's. Our centre was designed by Norman Foster, so he's from the Greater Manchester area, and it's a beautiful space and place. You've got to remember that treatment takes actually a few minutes on the couch, but in the room, maybe half an hour or so. And actually, so a bit of a space where they can go for advice and support, and just to get away from the hospital environment. That also brings me on to not only the support that Maggie's can provide, but also it is important that people are signposted to the services that are available in Manchester, because many people will never have visited Manchester before and won't be aware of the delights that are on our doorstep. We don't have Disney, so Jacksonville may still be an attractive place to go, but there is a lot going on for families. Our plans for research. I'm nearly done. So our plans for research, patient outcomes. What essentially this means is if you're going to give a new treatment and one that you've invested a significant amount of money into, you really should be collecting data as to the efficacy of that treatment. How effective is it? What's happening to side effects? What's happening to local control of tumour and survival, and all those really, really important things. So we're going to collect outcomes on all patients treated at the service. We will follow up patients at the Christie initially. We think that's very, very important, especially for a new modality, but eventually that follow-up can be devolved back to the referrers, where I'm sure the clinicians would appreciate that, and also the patients appreciate that. And we also need to look at novel approaches for follow-up, by video or telephone or whatever. And so we have systems in place for that should, at such time that those are required. We will be publishing our results regularly, and that will allow us to refine and define those patients that will benefit most from this treatment. As far as research is concerned outside of the outcome arena, we will be conducting a whole range of different types of research in that fourth room and in other parts of the campus. We've got the Manchester Cancer Research Centre on the campus, also basic research, preclinical research, translational research. In the centre itself, the numbers of patients that we have factored for the indications, the patients that are currently going overseas will fill probably about 30–40% of our capacity. There is capacity that still needs to be allocated, and there's a huge conversation going on nationally about clinical trials. Clinical trials in adults, teenagers, primarily. So we are very keen to cater to those trials. So in summary, protons are not new, but I really do think the technology has matured to a point where we can get the most out of them. It seems like an incredibly long journey since I first got involved in this, and would actually have liked things to have gone much quicker. But actually the way things have gone, we have come along at the right time in terms of the technologies that are available. There was a leap just before our procurement process in terms of developments in the technology, and that scanning beam technology was sort of on the horizon, but it was there when we went to procurement, and that was absolutely fantastic. So we've locked that in, and also our technology is upgradable, another reason why we've gone for the larger gantries. Protons are an additional tool to treat cancer. The proton service does not replace the standard radiotherapy service. I will still be practicing radiotherapy with advanced X-ray methodologies, and be very proud to do so, knowing that I'm doing the best for my patients. So for the great majority of patients, standard X-ray-based treatment is entirely appropriate. And the more I've been involved in the Proton project, the more I've realised that there is still very much a place for the other advanced forms of radiation therapy. X-ray-based therapies could just be more robust. And we make no apologies if we have issues with the centre and we're unable to treat with protons, which can happen. We will be using advanced X-ray approaches, as would any proton therapy centre around the world. There are some patients you may want to transfer to another proton centre, but they are rare. Patients and families who would have gone overseas will now be treated in the UK, a lot more convenient, and of course, as I said before, access to those who previously couldn't have travelled, I think, is a big plus, having a service in the UK. And we as a centre are very proud to join that service later on in the year. Whilst protons promise a reduction in toxicity, there is still toxicity. It is not toxicity free. It is not necessarily the Diet Coke version of Coke or the Pepsi Light version of Pepsi. There is still toxicity. And actually some of our patients who went abroad came back with skin reactions that I hadn't really seen with standard X-ray therapy. And it's because protons do tend to deposit a little bit of more dose in the skin than perhaps X-rays do. And so actually you do see quite significant skin toxicities. So it is a balance. And I think being familiar with both technologies and the toxicity profiles helps you to select patients. That's so much better. Co-locating and integrating protons with established cancer services benefits patients, end of fact. I have seen that all along the journey, discussing with colleagues how we're going to develop services for these patients. Having those services right next to you and integrated is a massive plus for patients. And also integrating the clinical service with research. I really do genuinely, honestly believe that it will make the NHS a world leader in the evidence-based use of this technology. So I just want to say very briefly a few thank yous. Dr. Adrian Crellin, who is NHS England lead for proton therapy and has done for many years, done an absolutely fantastic job steering the wider project through. Dr. Chang, those weekly phone calls that I mentioned, to Yen. Teams at NHS England who have been fantastic in the Christie, and also colleagues and patients. We've done a lot of outreach, going to other centres, asking their views on the service, how can we make it as smooth as possible, and we've engaged with lots and lots and lots of patients, and they've given us some fantastic advice, and that has moulded our approach also. But of course all we can do now is wait for the service to open. Thank you.